Good afternoon, everyone. So we have a very interesting topic here today. Future of accountable care and how population health intersects with genetics. And we'll try and make this a smart and controversial conversation to keep everyone's interest going here. But first, let's start off by having our panelists introduce themselves. And I thought I'd give you a quick intro on the kinds of issues that we as a group had wrestled with. We'd love to invite input from you as well. And then we'll dive into some questions and open it up for broad Q&A as well. So please, Dr. Sumbul Desai, you want to start us off?
Sure. So I'm Sumbul Desai. I'm Associate Chief Medical Officer for Strategy and Innovation at Stanford HealthCare. I'm also a clinical assistant professor in the Department of Medicine. So I'm focused, my work is mainly focused around developing clinical care model innovation, and so really thinking about the intersection of clinical, digital, and patient experience.
Hi, Paul Saarinen, co-founder and CEO of Miinome. We're exploring utilization of genomics and environmental data for matching and consumer services. We've been working on this for about 2 years. My background is in digital marketing and advertising for the last 15 years.
My name is Rony Sellam. I'm the CEO of a company called Sectera. Our service is called Insight Tracker, and we sell directly to consumers. And the concept is simply to provide personalized health recommendations based on blood biomarkers. So we sell directly to consumers. And prior to that, I was running a bunch of different digital health companies, selling primarily to providers, electronic treatment plans, and other products that can drive personalization as well.
Hi, my name is Helen Figge. I'm Vice President of Global Clinical Integrations for Alere ACS. And we orchestrate and accumulate and assimilate and execute on various pieces of data, regardless of where the source is from, and make it clinically relevant to the end user, and also the consumer.
Thank you so much. So between our esteemed panel here, we have a very interesting nexus of folks. We have folks that have been working with population health and really trying to find the best of what's working in that group. We have folks that have been involved in digital marketing here, and marketing in detailed genotyping and testing, as well as with Helen creating the connected health ecosystem to really enable some of the advances we're talking about here. So we thought we'd have a robust discussion. And as much as the topic today was about how do genetics and personal genomic testing and the accessibility of it really impact the future of population health and ACOs, we also wanted to take a decidedly consumer-centric angle to the conversation here. So you'll hear us talk a little bit about seeing it both from a physician and a consumer perspective. So with this topic, $1,000 genome is upon us, and the implications are really quite staggering if you think about it. And genetic testing, if you don't actually get into the full sequencing, has actually been around a long time. For anyone that's been involved in a fertility or maternity situation, you know that there's a variety of testing that's been around a long time, and it's even cheaper and more accessible in some ways. And as we were thinking about how you start to incorporate this in the current construct and understanding of what ACOs are doing in population health, it raised some very interesting questions. We'll start to debate some of those today. Population health and ACOs, for starters, you're all familiar with the Pioneer program, 220-odd companies that have been a part of that over the last couple of years. Data is available for about 205, and the most recently released test there essentially suggests that the results have been mixed, right? Over $600 million worth of savings and $300 million worth of bonuses paid out across these. But if you look more closely, less than 25% of these participants actually met both savings and quality targets. And in fact, if you look at how many even took both upside and downside risk as a part of that equation, it's even fewer. So the ability to actually understand what population health means and really even take on risk is still quite compromised. So in this environment, if we were to introduce genetic data about individuals and expect physicians to incorporate that in their decision making, how effectively would that work? And then you think beyond that and say consumerism is here. And there's a lot of hype, and the truth is consumers are more engaged than they've ever been. If you look at most surveys in the marketplace, you'd find that greater than 60-70% of surveyed consumers are hungry for data. They want to see more personal health information. They want that incorporated into their diagnosis and how they interact with their providers. But at the same time, their level of awareness of the breadth of solutions that are out there are also quite low. And in fact, if you look at the adoption rates of something as simple as even Fitbits and fuel bands, you find that less than about 4 million units have been sold in the US and about 13.5 million worldwide. It's about a 250 million market in the US, which is a drop in the bucket, globally, which is a drop in the bucket compared to our approximately 3 trillion national health expenditures. And most folks say they drop using it after 6 months' time. So how do we reconcile this desire and the interest with actually awareness and adoption? And how will personal genomic testing, where almost 60% express an interest in wanting to take these tests, but almost 40% of them don't understand what they're going to get with these tests. They actually think it's a medical diagnosis as opposed to a tool, and the fact that they need to have dialogues with their physicians to understand them. So we have a very interesting set of challenges here to reconcile. So without further ado, I wanted to start us off with a couple of questions to our panel here to go after these, and feel free to jump in at any point and join the conversation. So first things first, let's talk about population health. Is the jury still out on it? And amongst our panelists here, I would love to get your perspective on what do you think is really working well here? Do people understand it? And where do we still have a huge gap that needs to be addressed?
I'll start. I think the skepticism level is pretty high all around the industry. I think the skepticism level has been growing the last few years. 10 years ago, we started thinking about and seeing those alternative quality models coming out and the contracts being signed left and right, especially here in the state. We are here all these years later, and all of us optimists thought we'd be much further along. The Pioneer ACO results were bad news for, I think, everybody, and worse news if you were looking at it as a hopeful player in the healthcare space. So I'm unfortunately becoming pessimistic about it, and it's primarily driven off of the fact that I find very few people able to articulate what ACOs actually are, what population health is expected to achieve. So here we are asking care delivery networks and organizations and even individual physicians to do something that very few of us are capable of articulating, explaining, and selling.
Helen, do you want to comment on it as well?
So I think the concern here is the constant regulatory environment we live in. We're constantly being told what to do, how to do it, when to do it. So the skepticism runs high, but also I think at the end of the day we have so much information out there that it's almost becoming irrelevant. It's sort of like, you know, we had that analogizing it in that saga of when everybody was collecting Beanie Babies. You couldn't get enough Beanie Babies and all of a sudden they dropped off the face of, you know, the earth of the toys. I sort of analogize it, the data being out there, we're storing, collecting it, we're trying to assimilate it and let everybody have it and spoon feed it in one certain segment, but each clinician looks at data differently, and we've got to start really identifying what data is relevant, who needs it, when do they need it.
So Paul and Sumbul, I'll ask you to take a positive angle to this. What do you think is working well, and how do we actually reconcile some of these issues?
So I think from the provider perspective, I think the jury still is out. I mean, I'd be lying if I didn't say that. But I do think it's forcing us to have some conversations in the provider systems that we normally don't have. So really organizing around operationally, how do we set ourselves up to function outside of the fee-for-service world and really start thinking about quality and value-based care. It's also enabling the ability, you know, we have an ACO that we just launched with our university, and it is allowing the conversations of what are the new care models that we could deliver and how can we be innovative, because we have an employer, i.e. and a payer group that are actively willing to fund some of the innovative ways that we want to deliver care. And so I think that's a positive. I think we wouldn't be able to get, for example, we get reimbursed for video visits and storing forward pictures of your dermatological conditions, and we wouldn't be able to do that if we didn't have this conversation on the table. So I think that's actually been a positive. And so we'll see where it goes.
Yeah.
I think the way I would look at it from a positive direction, the fact that 5 years ago, I would never have imagined sitting on stage in a health conference is probably testament enough that people like myself and that have B2C marketing backgrounds that and other people inside the industry that have really cultivated the consumer messaging and marketing platforms that we all use today are starting to recognize the opportunity and the challenge inside the industry. That I think, if anything, that those numbers will increase as you have the correct people in there to deploy and come up with the right ideas.
So I'll throw a question back to the audience here, just by show of hands. How many of you believe that payers and providers have a clear definition of what population health means? Show of hands.
Come on, be nice.
How many do you think actually know how to price risk or actually can tell you what a fully allocated cost of care looks like in their hospitals? Wow, we've got a really pessimistic crowd here. And how many do you think actually have even pivoted their mindset towards being a bit more retail-centric? We've got a couple of hands here. So at least the payers in an exchange marketplace are starting to move in that direction. They recognize that the economics of cross-subsidy are gone. The average provider could take 80% of their contribution margin from the commercial book in the past. It's down to 55% in the new world. They have to play consumer ball. For providers, that story is coming along a little bit slower. That being said, a question to our panel: how do you see consumer and physician adoption evolving for digital health technologies in general, but in particular, personal genomic testing? It seems like the science hasn't caught up yet, the correlation between genotyping and disease states, and yet there's a ton of interest around this. How do we reconcile the two? Paul, do you want to lead us off?
Yeah, no, it's a really interesting question, and my company doesn't play in the clinical space for obvious reasons of regulatory and other things. It's not that it makes people afraid, but obviously it's a barrier to entry. What I've seen in the people that I've talked to and my experiences in this with this question really revolve around, I think, looking for more use cases and outside the clinical setting, and that I think that's a really great way to boost access and lower the barrier to entry. We saw that with a couple other consumer genetics companies getting traction and growing as soon as they got into the consumer market. But looking for additional values outside of just clinical. I think some of the problems too is we've got physicians that are overburdened with enough information already, and this is yet another area of expertise that they're supposed to handle. The other problem I think that would be interesting to solve is the bottleneck with the genetic counselors. Now, I don't know if you know how many genetic counselors are certified in the US, but it's like 2,000. So what happens when we have a population that starts being able to have access to this information, and you get your 1-minute conversation with your genetic counselor? What does that mean? I mean, that's not workable. So we have a lot of challenges in front of us, which I think present a lot of opportunity as well. So that's kind of my take on that side of the industry.
So Helen, you want to comment on that?
So I think the data that would be presented, I have a difficult time having genetic testing without a purpose. I think every test needs a purpose. We can't just be testing for an answer. And I think if we can cage genetic testing for the purpose of why it is being executed, it's valuable. If people otherwise are just doing genetic testing for finding a piece of data that otherwise is going to be meaningless to them, I think that's very dangerous, because at some point you have a piece of data, it may be abnormal, but it may be a normal abnormal, and then what does it mean? And it creates unnecessary scares in the environment, unnecessary workload for clinicians who are already overburdened. You talk to a clinician today, regardless of where they are in the United States practicing, and for that practical purposes in other parts of the world, people, they're overburdened. And we're adding one more layer, and if they don't understand it, that's far more dangerous than if the test was not performed at all without correct supervision. So I think we have to balance it and really lead by example instead of constantly throwing one more fantastic thing out there in medicine just because.
So maybe I'll ask you the question, do you think the industry should self-regulate or add more regulation then?
I would look to subject matter experts to tell me why I would need a genetic test, for what purpose, and what would be the conclusion of it, and create guidelines that would be able to be used, and then have the clinicians, based on their intelligence and their ability to, take care of the patient. We need to give healthcare back to the clinician, period, and let them help us redirect wherever we have gone awry, because we have never before had more technology, more diagnostic testing in the world, and we still have the third highest rate of deaths from medical errors. So there's something not right here. And I think that's where I get nervous.
So Sumbul, along those lines, so let's say we give healthcare back to the clinician. And what is the current experience? What is the tool set you think the average clinician needs, or the issues that need to be solved? We have EHRs. They've proven themselves to be ineffective aggregation points for clinical decision-making at best. What are you seeing in terms of developments to solve that problem, to put them in that cockpit, if you will?
So just to make sure I understand the question, to put the physician back in control, is that the question?
Right. What do we need to do from a data aggregation, visualization, or presentation standpoint to help?
That's such a loaded question. From a provider perspective, it's such a loaded question. So it's such a big question because right now the shift in healthcare, first of all, that's affecting clinicians is there's consolidation amongst hospital systems, right? And so that's changing the metrics that we are all judged by and how we get paid. So number one, and not to say that physicians are purely compensation driven, but I do think there is a lot of emphasis now on compensation where physicians are concerned and feel like they don't have enough input in that. So, again, this is the reason I said it was a loaded question, is it really makes me look at more of a macro level, because I don't think it's as simple as, what technologies do I need to be able to be an effective practitioner. So I think having input in terms of how practices should be run, allowing them to truly get back to being able to practice medicine and be worried less about every patient satisfaction score, seeing X number of patients in time so that they get the number of RVUs going. I mean, there's such a stress on providers right now that are not being able to practice the way they would like to, not being staffed enough, really thinking about, what's the provider care team look like, and really getting providers to practice at the highest level of their competency, and then leveraging other care team members to be able to assist. And so I think that would then allow for providers to have the time to be able to look at more complicated information like genetic information and have more meaningful conversations with their patients about it. And in that sense, if we had that perfect practice model going, I think then things like an EHR where the data is visualized correctly and physicians are involved in the development of that. So I think that's another really important part. I think having patients and physicians involved in the development of how data and information should be transmitted and communicated back and forth would be really helpful. I also think right now, some of the EMR companies really dictate what information we can actually get. And so thinking about how do we partner closer with the EMR companies, we have a strong partnership with our EMR organization, and that's been really helpful in terms of pushing the needle, in terms of being able to leverage new technologies and visualize and integrate new things. So, I'm not sure if I completely answered your question, but I think it's a multi-pronged approach going up to some really macro levels in terms of how we operationalize our business.
So I'll be cheeky and paraphrase, and then Rony, you should comment. So it sounds like we need to fundamentally change the business model of healthcare to make providers more effective and be at the center. Okay.
Absolutely.
Go ahead, Rony.
Sure. Sorry.
Yeah, a few comments I'd like to make. First one around the population health and ACOs in general. I think we're still in a place where hospitals, it took me about 10 years in healthcare, and then I had a conversation with an older member of my family who asked me to explain the business model of hospitals. And I said, it's a little bit like a hotel. You make money when the bed is occupied, and you don't when the bed is not occupied. Until we change that fundamental premise, I'm not sure how we can solve any real issues around quality and value, especially. That's the first comment. The second one has to do with, so I was born in Geneva, Switzerland. I grew up in France, and I've been in the US for about 15 years. And when I moved here, I had to buy a car. And at the time, I remember buying a car by going to a dealership, and the sales guy had all the data, all the information. I had no information. Today, if you go buy a car, by the time you get to the dealer, you already have your quote, your price, the guy's job or gal's job is simply to shepherd you through the process and facilitate you procuring your car. Now, that asymmetry of information and the power that you get from that has happened in healthcare a little bit, but I cannot imagine having a physician between me and my data, especially my genetic data. And the reason why is because if you take 100 primary care physicians and ask them about genomic information and the connection between SNPs and conditions, you'll see a blank stare. Most people have no idea what it is, what it means, and certainly not how to incorporate that into clinical practice. If that's the case, we have to go towards the CAR model, which is provide the consumers with the information and allow them to make these decisions. I don't think we can change the hotel model without making the consumer basically be in charge of the system.
And I'll add on to that. I think there's a lot of benefit that we'll experience with that move, and you're seeing that push happen today, right? So if I look at, if I open my iPad, I have a HealthKit app. I probably have more telemetry data available at my fingertips than my doctor could ever handle, right? So you can imagine, that information is here today, and the control over it is yours. And once that you've been able to opt out of HIPAA and have that data available for other people to use or to share for discovery, it could be for your own benefit. It doesn't have to be necessarily clinical in nature. It can be consumer driven as well.
So,
can I just make one comment? My only pushback on the analogy with buying a car model, a lot of times now though, when you go into the dealer, you're like, what's the salesman here for, right? And so I think the relationship with the physician, at least from a physician's perspective, we don't ever want to be in a position where the patient's like, well, what are you here for? And I think I think the conversation needs to be about educating the patient, but also really giving the provider time to be educated. So yes, we may not be experts in internal medicine or primary care on genetic information, but the physician and the consumer are equally just as intelligent to be able to have those conversations if they have the time to actually be well informed and have a good educated conversation where physicians really serve as partners to your patients as you kind of shepherd through your life, as opposed to because then I feel like we're just moving from the direction of it all being in healthcare to now all being on the consumer side, and I'm not sure you're going to get the outcomes that you want there either. So I think it needs to be a partnership.
So you guys have touched on three, shall we call it, semi-universal truths here, right? One, the incentive and the business model in healthcare is changing. And you could argue about what percentage of payer-provider contracts out there have a risk or value orientation, but the truth is it's moving slowly. Some would say it's 25%, some would say it's 3%. But there's an element of upside or downside risk, whether you're talking about PCMH capitation and so on. There's a second universal truth here, which is that consumer transparency will continue to grow. There's no question about it. And then the third universal truth is it's going to change the payer-provider interaction. So you've got a pocket of people out there that say primary care as we know it is going to change. That this relationship between payer and provider is going to shift, where 80% of what a primary care doctor used to do will be replaced by better, more precise diagnostic technology. So what is the role of the physician in this new world? And how can they incorporate what this looks like? And do you think that's generating a two-tier healthcare model where you're going to have a set of healthcare entities that can play in that space, and then you're going to have the traditionalists?
You know, I'm sure many of you are familiar with Iora Health, and I think they are piloting some interesting models where they really are, going straight to employers. That's one of the things they're doing. They're working, and they're really disrupting the care delivery model. So their model is to have a primary care doc. Generally, they work out of pods of 2 physicians in each primary care clinic, and then they work with health coaches. And the health coaches really are doing the day-to-day interactions with the patients. And so 150 patients to 1 health coach is about the ratio. And so this goes back to what I had mentioned of really allowing for providers to operate at the top of their game, so they're doing less administrative function, and they're spending much more time in issues, dealing with patients and issues where the physician is really best used. So really like high-level diagnostic conversations, but the health coach is really the day-to-day touch point. And the patient satisfaction in those groups has been amazing. They've achieved really strong clinical outcomes. So I think those type of models will really be what we start to see, and that will allow for providers and physicians to really raise the game of where they're providing, at least in primary care, how they're delivering care, and the knowledge level that they're operating at.
So Helen, do you see a world where this health coach goes digital?
Yeah, I think this is really where healthcare is leading, to keep the patient out of the hospital, keep them well. People are getting sicker quicker, living longer. You know, as the old saying goes, with pre-diabetic states, people are obese. 3 out of 4 people sitting, if you sit on a park bench, walk by, aren't their ideal body weight. So mobile devices are going to become very invaluable in this process. And I think health coaches, being able to have the data in real time, regardless of where that information is coming from. We're in an age where everybody has a mobile device, a mobile application, and we're going to need a resource, an entity that's able to accumulate this data, assimilate it, regardless of where it comes from, and be able to present it to the clinician for use. And that's exactly what we do at Alere ACS. Regardless of where the data comes from, we're able to capture it and present it in the way where it can be acted upon. So we are going to see more and more of this activity, and I could see it even with genetic testing. If someone is in a rural area, we want someone in rural Idaho to have the same opportunity with stage 3 breast cancer with liver mets, for that same person, that same woman who lives next to Sloan Kettering off Madison Avenue. And that's always what we've strived for, but we haven't been able to get to it. But since social media and digitalization of healthcare has become very, norm, we're seeing this. The key is to capture the data. Again, I always say data is only relevant if it's helpful and meaningful to that specific patient, and then act upon it. But if we have someone collecting data and it's sitting out there and it's not acted upon and it's detrimental to the patient, there's a whole new liability issue there that someone who knows legal stuff would have a field day with. So mobile devices definitely have a play as we move forward and in these models. And I think ACOs, if we get to that point where people understand them and really embrace the models, whatever that model may be, based on the region or the community that's designing it, the mobile device is going to be invaluable to collecting data.
So I want to touch on one point you just made, Helen. There is a convening of data that's going on here in order for this to work effectively. Mm-hmm. And there are incumbents in the health system that believe it's their right to do that convening. There are also several new entrants outside of healthcare that believe that they have a right to do this convening. Apple HealthKit, for instance, is making that play. You have IBM's Watson. You have Philips and Salesforce that are trying to do it. Maybe Yelp will be next. So Rony and Paul, do you want to comment on, do you see the new interlopers or non-traditional aggregators emerge to serve this convening need in healthcare?
So yes, I do. And I think that there are very interesting primary care models being developed and tested everywhere. Our health is a very, very interesting one. I completely agree with that. I recently went to a Minute Clinic to test it out. I loved it. I think it's an amazing way to deliver routine, simple healthcare. I think Aera Health is a version of that. I think it's very, very far from, we're in Massachusetts here. Think about what Parsons Healthcare looks like. We're still going to need the hotels there. We need heart surgery. CVS can't be a place to do it, right? In my opinion, we're going to see entrants that are doing interesting things that are going to try and disrupt this 18% of GDP that we're consuming. A lot of people have tried. We've all been around healthcare, hopefully, for a while. We've seen so many situations, from Steve Case and Revolution Health, all the way to, recently, I don't know if any of you have seen what Samsung has been doing with the huge healthcare team they created that all of a sudden disappeared. I'm not sure what Apple has done, frankly, besides giving you, I'm a huge Apple fan, by the way. I have an Apple iPhone 6. I play with the HealthKit. But I was extremely disappointed to see that it's basically a fancy Excel spreadsheet. You put a number in, and it shows it to you back in color on a chart. I think I've been able to do that for a few years. So I think the reality is that we will see that happen, but I don't see it happening from within the payment system. I see it happening with money being allocated by the consumer. I think the choices will end up being made by the consumers. And so consumer-oriented companies, in my opinion, will drive that difference and will drive the ability for, and be the forcing function to make change happen.
So Paul, almost 1.4 billion in VC funding going towards these consumer technologies just in the past year alone. That's with a B. And over 140 plus companies tinkering in this space.
Yeah. It's funny, I actually made a joke about this the other day. Coming from outside the healthcare space, and doing this work for nearly 15 years, I think what's been interesting is that I'm on stage having this conversation about what type of data to use, how is it relevant, and utilization. We've been doing that in digital marketing and advertising for a long time, and we're very, very good at it. The old adage was, I know 50% of my marketing and advertising budget is working, I just don't know which 50% it is. It starts to sound a lot like, I know 50% of my prescriptions are working, I just don't know which 50%, right? So the solutions that we crafted in the consumer side, things like customer relationship management systems, focusing on going more one-to-one marketing, I made the joke that I think Facebook could be described as potentially the largest electronic health record site because of all the data around that individual and all the learning that we can pull and mine from that information. So the question I have is maybe we don't have the right data sets in this industry to make better decisions.
So let's bring it back full circle to pop health, and then I want to open it up for questions for the audience. In the future, in the population health model with health concierges and coaches and all these other intermediaries in play, is the person who is your digital health marketer going to have a better relationship with the patient than the doctors themselves?
I think they already do.
I think it could be both of them. So I think the digital marketers that work for the physicians in our hospitals, I think we're starting to pay more attention to that, obviously. And I think health systems can't ignore that anymore. And so we're spending more time on digital marketing and with our marketing team. So when we're launching a new program in January, and I was just having this conversation with someone earlier today, I have a marketing person involved in the development of that program from day one. Because we want to make sure that the consumer understands it. It's a program that's really thinking about the consumer from the get-go and not necessarily from the provider's perspective.
Rony, Helen, yes, no? What do you think?
I hope the answer is no. I really do. But I do want to say there are models out there where hospitals have taken it to the next level. I've seen a few in Texas that have hired executives from the Four Seasons, et cetera, to really develop how that hospitality plus healthcare model could potentially work. I really hope that we'll be able to keep physicians and healthcare professionals in general as you said earlier, Sumbul, at the top of their game. We all need them. We all love them. Their job is not easy. And I think data should be a supporting mechanism, and we should keep them as the oracle, being able to read that data, as opposed to having to deal with all of these ACO requirements we're putting on them, which is not making their life easier.
So there's no replacement for a clinician. The technology that's out there today, regardless of what it is only the enabler to help them do their job, to help us. My EHR or my portal can't answer my question 1 in the morning when my son, split his head open after playing hockey or something like that. And I think there could be a new evolution. The EHRs out there, I think if they were more user-friendly to the clinician, there was a study out there that says we actually cannot multitask as humans, contrary to what we think we can. And EHRs force us to do that. So if someone sat down probably with a developer for about 3 days and really reworked everything, I think we could see a whole new shift, including really taking for granted or not granted workflow of clinicians. I think, if we could step back before we reinvent or currently, move on to the next level of healthcare and really fix what's out there, I think we're going to make a dramatic change. But there's no substitution for the clinician and that personal touch.
Thank you much. So let's open it up to our audience here. I'm sure you have tons of questions to throw this way.
Thanks a lot. You covered a lot of ground. I just want to kind of rephrase that, or maybe you have some comments. You started off with population health, risk-based reimbursement. One of the problems with risk-based reimbursement is nobody understands it. We're back in the 1980s, 90s around capitation. Everybody thought it was about lowering cost, really the marginal cost of a healthcare transaction. It's not. It's about lowering the, rather increasing the marginal effectiveness of each healthcare transaction. That is, every time I encounter the healthcare system, it should reduce the potential for me to have to encounter it again. That's a very different mindset. And it's really about clinical risk management. If you think about what a clinician is involved in doing in a clinical team, it's not about preventing you from what you have today because you have it. It's about influencing the future course of the condition. So that risk management, so the primary data in the risk management becomes the clinical data. That's what's going to drive the business going forward, and that's lost. Now the problem here, but it's a worldwide phenomenon, I've worked all around the world in this, is that there are no good, meaningful, actionable clinical data sets. And the issue isn't about bringing the data together. It's, if I do bring it together, are they comparable? Are they scientifically valid? Can I do any kind of longitudinal analysis on it? And most importantly, can I use this data to understand the particular needs of the individual patient? That's where population management falls flat, is it tends to put the individual aside when in fact it's those individuals with chronic conditions who are the ones who are costing the most dollars, and every single person with a chronic condition is different. So that's number one. Second is, I get all kind of fuzzy when people talk about genomics as if we have magic bullets. And what we've really learned, if you think about it, the last 20 years about genomics and DNA and this and that, the fundamental thing we've learned is that it's less important than we thought. Proteomics, microbes, we have more microbial cells in us than we have human cells. In fact, in many respects, we are just an expression of a microbe. If you do microbial transplants, you can change the personality of mice. How you metabolize a drug depends on your microbial makeup. So all of these things together, it's very complex. The genome is just one small component. And I get very upset when people are trying to use that as a magic bullet for a consumer when it's actually just completely unreal. So that's that piece. And then the other thing I was going to say, which is very important, is in my experience and practice, the transition to risk-based reimbursement is critically important. It is remarkable how quickly physicians, administrators, and everybody suddenly ask, does that drug do anything? Mm-hmm. I tend to deal with complex patients, renal patients, and others. If you're a renal patient, you probably have 10 to 15 drugs that you take at home. Nobody knows whether they work. true. Nobody's really done the studies, but suddenly they ask it. The problem, which was raised by a nice woman on my far left, is that government then becomes prescriptive, because government has to feel as if there's some certainty around quality. And so suddenly we have all these different benchmarks we have to meet, which really don't have any data behind them. Mm-hmm. It's very interesting. And the problem is, I can optimize care within that overall risk-based reimbursement, but if you're telling me to do the opposite through these prescriptive measures, my risk actually goes up, not down. Okay, so I just throw that out, and I don't know whether anybody has any comments about it.
I'll comment, just one comment on the genomic point. I think it's very early to be able to say how important genetic information is going to become. I tend to look at it as a language that we're just now starting to learn how to speak. We all assumed that we'd be able to speak it fluently the moment we know all the words, but we don't really know how to put them together quite yet. So in my opinion, it is going to be a gigantic revolution. And it hasn't quite happened yet, I completely agree, but it will be huge. The moment you can start sequencing a tumor and then sequencing the genome of a particular patient and then tailor the regimen to that information, it might be that cancer becomes a chronic disease. That's what we're all hoping for, I think.
I'll add to that. I think that your frustration with the overselling of the utilization of genomics has been happening for quite a while, and I can appreciate that frustration and the overhype of the industry, because we all know that right now, I mean, and there's been plenty of studies around this, it's not usually just genetics, it's genetics plus environment, right? We've done a really, really great job utilizing environmental data to personalize product and service recommendations, and that can move and add value by adding the genetic component as well. So I think I agree with you guys, is that it is very early and we're still getting up to speed on this.
Great, thank you. I know there was another question.
Thank you very much. I just had one question, and it's different for the consumer-facing companies versus the kind of the providers. Essentially, what we learned earlier today about the patient voice and how the patient should bring the lifestyle experience and the doctor should bring the medical expertise, and then they can come together and have a good conversation. You guys kind of hit on it, but I'd like to hear what you're doing now to change that conversation so that when the consumer comes in for the consumer-facing companies, they can have better lifestyle expertise, and when the doctor comes to the table, they can have better medical expertise. How are you changing that now?
So I can answer that quickly. I think we look internally what motivates a specific individual to want to take care of themselves. I think that's like the number one question still out there for what they otherwise call patient engagement. So trying to understand the sweet spot of a patient who would want to consistently take care of themselves, particularly with a chronic disease that they're going to have the rest of their life. And from the healthcare perspective, I think being able to understand how they want to work through their day. I think that has really been lost to the wayside of clinicians, because cardiologists think differently than oncologists, think differently than the OB guys. And I think that whole conversation just got lost. And I think we have to step back into that. And I said, there's really a really easy fix. To sit down and really get the logic behind some of the simple screenshots in an EHR. And that's what, regardless of where the data is coming from, to be able to present the meaningful data, to say a cancer oncologist, to see a cancer patient versus someone who's seeing a patient for a GYN appointment.
Sumbul?
What we're doing actively right now is a few things. So we've actually created an in-house design team, so we do a lot of ethnographic research. So for the first time, our provider, maybe not the first time, so I shouldn't say that, but as a provider system, we actually spend a lot of time thinking about personas of our patients. And so we're currently, as an example, redesigning primary care, and we started with a large user research study and really partnered with our design school. We actually have folks from IDEO and Frog that we hired and brought them in internal. And so really trying to spend time to understand not just consumer behavior, but just behavior and like, how do you want to get your care? Do you like communicating with your doctor via phone, or do you like doing it by text? What do you like about your visit? So really trying to understand that, and we're doing it by specialty. So we have a large initiative like that in primary care. We're doing the same thing in cancer, so spending a lot of time doing user research and really using design thinking to revamp how we're delivering the care process. And then taking it to actually even the technology side. So we are building our own PHR on top of our existing EMR. So we use Epic, and Epic comes with the MyChart portal. We're actually redesigning our own portal, really using agile, the agile methodology, and getting user research, doing quick inputs. We have patients sit on all of our committees where they're reviewing a lot of these screenshots to say, does it work for them? And we have providers sitting there as well. So we're really trying to gather that research up front and incorporate that in the way we deliver care.
Great, thank you. Any final questions? We have 30 seconds.
We started the conversation talking about healthcare organizations, and maybe that's been a little bit of a disappointment. And a lot of things we're hearing about, the idea of having genetic information about a population, having all this information about populations, would be so great from a policy perspective, from a public health perspective. And I'm just wondering, is there any chance that we're trying too much to fit like a square peg into a round hole in asking providers and hospitals to be doing the bulk of population health management? Just wondered what your thoughts are.
Versus
Versus a public health agency, or versus thinking more in terms of regulation and policy, how we allocate our resources. But
if you have permission to take a minute and just quickly run down, anyone want to take that on the panel?
That's tricky. I think yes, I think we are, but I think there's also the reality of in order to be able to create some of the processes around population health, you do have to have the provider systems involved, because it's that data sits with us, and so I think it needs to probably be a partnership. But I think putting all the onus on the provider may not be completely successful, but I think it needs to be a conversation, because obviously regulation does play a role in it as well.
So we've got a desire for more public-private partnership here. We'll close on that. Thank you so much for our time. Applause for our panelists.